Today our guest speaker is Dr. Maria Matias from Spain. She's going to lecture on high-risk myeloma. This webinar is brought to you by Mumbai Hematology Group, supported by Jensen, Nirvin, and managed by Perfect Square. I thank Dr. Dhara, Mr. Hitesh, and the team from Jensen, Mr. Paresh and their team from Nirvin, Mr. Yash Kalpesh and their team from Perfect Square, Executive Committee of Mumbai Hematology Group. Today, our chief guest is Dr. Radheshyam Naik, medical oncologist from Bangalore, and I'm grateful to him. Our guest speaker, of course, is Dr. Maria Matias from Spain. All our discussants were themselves eminent hematologists or medical oncologists. There are participants today from almost 27 countries all across the globe, and I'm grateful to them for sparing their Sunday morning, afternoon, or evening. Just to introduce the subjects for the next weekend, Saturday, 7 p.m. IST, we have chronic myeloid leukemia by Dr. Vivian Euler from Seattle. And the next Sunday morning, we have update 2022 regarding the classification of mature B-cell lymphomas by Professor Fellini from Italy. Our discussants today are very important personalities from all over India, and they are alphabetically shown here. To introduce them briefly, we have Dr. Aditya Jandial from Chandigarh, Dr. Aishwarya Raj from Ahmedabad, Dr. Eni Kanchanba from Delhi, Dr. Arijit Nath from Kolkata, Dr. Asif Iqbal from Guwahati, Dr. Darshana Rane, Mumbai, Dr. Girish Balikai, Dharwad, Dr. Karthik Bomanan, Adyar, Dr. Ketan Nathani, Mumbai, Dr. Meher Lakshmi Konatam, Hyderabad, Dr. Monica Chenna Reddy, Bangalore, Dr. Mukul Agarwal, Delhi, Dr. Nilesh Vasekar, Nashik, Dr. Rahul Arora, Nagpur, Dr. Rajkumar Ramaswamy, Madurai, Dr. S.S. Ray, Kolkata, Dr. Vikas Goyal, Raipur, and Dr. Vivek Radhakrishnan from UK. It's my pleasure to introduce our special guest today, who is going to inaugurate our webinar, and that's Dr. Radheshyam Naik. He requires no introduction. However, to complete the formalities, he is senior medical oncologist at HCG Bangalore. He is MD, DM, is pioneer in the field of medical oncology with more than 25 years of strong academic experience in this field. He was trained in Kidwai, Bangalore. He has received advanced training from the world's leading institutions, including MD Anderson, International School for Cancer Care, Oxford, and University of New South Wales, Australia. He is regarded as an eminent oncologist and having experience of visiting renowned cancer hospitals around the world. He has had an excellent academic career in managing all types of cancers and hematological disorders with several peer-reviewed publications in leading journals. He is pioneer conducting various drug trials, conducted over 50 chemotherapeutic agents in national and international trials. He has special interest in bone marrow transplant program and has also undergone advanced training at Hadassah University, Israel, Detroit Medical Center, New York Hospital, US, Cornell Medical Center, Harper Hospital, Michigan, US. He has been a major contributor in development of field of hematology and transplant in Karnataka. He performed the first intra-arterial chemotherapy through port in Karnataka. Also is credited for performing the first bone marrow transplant in Karnataka. I request Dr. Radheshyam Naik to inaugurate our webinar and give some words of wisdom, especially for our fellows.
Thank you, sir. Good morning, everybody. I have to thank Mumbai Hematology Group for this kind invitation. And I also thank Dr. M.B. Agarwal, who is a good friend as well as a very eminent hematologist known across the country and the world. And today's talk is about the high-risk myeloma by an eminent international speaker. And I'm sure that you are going to have a good time discussing this and exchanging ideas. I declare this meeting open. And a few words about myself. I have done my DM medical oncology long back, I think more years than I like to think about, more than 30 years now. And at that time, the hematology was not that developed in the country, as a very few hematologists were there in the country. And we used to do both solid cancers as well as hematological cancers. And I have a feeling that having some basic working knowledge of solid cancers may help the hematologist to some extent. It is a very interesting field, an interesting journey for me, because we not only did the solid cancers therapies, we saw all new treatments coming up over these 3 decades, biological treatments, immunotherapy, targeted therapies, and all that. And it has been a very joyful journey for me. And I like the field of hematology and oncology for several other reasons. One is that it gives us knowledge in variety of related fields. For example, immunology. You need to have some basic ideas about immunology, about infections, because at least initial years of my practice, an infectious disease specialist was not available. So we had to deal with all kinds of cancers, leukemias, lymphomas, and infections ourselves. And some basic knowledge about genetics, which is becoming far more important right now. We are doing genomics, at least in all solid cancers, in some of the hematological cancers as well. And to some extent, my training was in cancer palliation, because at that time, again, there were no palliative specialists. So we had some help there also. Then we did a lot of this bone marrow transplantations, and I am grateful for HCG for giving me a platform, and we could do more than 350 transplants, and acquired a tremendous amount of insight into what this entails, including could do some mini transplants as well as bloodless transplantations. And I think I have had more insight into clinical medicine by my practice and reading about oncology. And a lot of these medical problems have been clarified in my own mind over the years by this kind of an experience. And last but not the least is the research mindset which an oncologist or a hematologist will have. Because the field is rapidly evolving, and unless you are at the cutting edge technology and you try to do clinical trials, some research, at least analysis of your own cases, I think you will not be able to really move effectively forward in this field. So I feel that you are all in a very exciting era to be students and early professionals in this field. And I wish all the best for you. And I hope that this seminar, this talk will be very helpful for you. And again, once again, thanking Dr. Agarwal as well as the Mumbai Hematology Group for this kind invitation. Thank you, sir.
Thank you so much, Professor Radhashyam Nayak, for those very, very important words and messages. I'm sure this will have a great impact on the audience. And you have spared your very valuable time on Sunday morning. Grateful to you.
Thank you.
We'll now move to the main lecture of the day. It's my pleasure to introduce Dr. Maria Matias from Spain. She has been a wonderful friend from Spain for India. She was personally present here for a couple of meetings in past. And during this pandemic also, she has helped us by educating everybody by repeated conduction of these webinars. And today, once again, there is a very important subject that she's going to speak on. Her formal introduction is important. So she's MD, PhD. She's consultant physician in hematology department, associate professor of medicine at the University of Salamanca, Spain. She's the director of the myeloma program. She coordinates clinical trial unit in Salamanca's University Hospital in hematology department. She also serves as coordinator of Spanish myeloma group with direct involvement in the design and development of clinical trials. She's coordinated many clinical trials in elderly and smoldering myeloma patients that have profoundly influenced current options for treating these patient population. She's a member of the IMWG, IMS, EHA, and ASH. She's published over 250 articles, papers in peer-reviewed international journals, and some of these have become key references in the field of myeloma. Her articles have received 29,452 citations, 19,268 since 2015, with an H index of 79 and 60 since 2015. She's associate editor of Myeloma in Annals of Hematology from 2011, and she has acted as a reviewer for top journals, including NEJM, Lancet, and Lancet Oncology. Among her invited presentations, she has recently contributed to the educational sessions of EHA, beginning from 2012, ASH, beginning from 2013, and ASCO, beginning from 2015. She has served on the EHA's Scientific Program Committee and Advisory Board since 2013 until the current year, and on the ASH Scientific Committee on Plasma Cell Disorders from 2015 to the current year. She's a counselor on the EHA board from 2015 for a 4-year mandate, member of the steering committee for the Society of Hematological Oncology, SOHO, member of the IMS board, and member of the European School of Hematology Scientific Committee. We are privileged to have her presence today to address us, and she's going to explore the subject of high-risk myeloma and its advances to us today. So over to Dr. Mane.
Thank you very much, Dr. Agarwal, by the kind invitation to be here with you today, this Sunday morning. And I am going to share my screen. And it is a great privilege to be with all of you today, discussing about I would say, a bit difficult topic, and it's high-risk multiple myeloma. But I will try to dissect the information I have, and we will have time enough later on for discussion. These are my disclosures. And the first important point is, what is the definition of high risk? And here you can see 3 different definitions. The International Myeloma Working Group defines the high-risk myeloma, those patients for which the overall survival is 2 years or less, despite the use of novel agents. Professor Moro defined high risk more or less with the same definition, those patients who died without, because of progression within 2 years from treatment initiation. And Barlogi, I would say that it was, well, more exciting definition for high risk, and those patients not being cured will be at high risk. Maybe this definition is more realistic right now, because you know how when the introduction of many novel agents in multiple myeloma, we are maybe in the right position in order to cure some patients with multiple myeloma, and those that it is going to be impossible to be cured would be high-risk myeloma. Let me move to the next slide, sorry. Just one moment. Yeah. And what are the factors that determine high risk in a patient with multiple myeloma? And here you can see some patient-specific factors, as well as some disease-specific factors that can confer high risk in multiple myeloma. I would like to start by the frailty. You know that myeloma is a heterogeneous disease. Myeloma usually affects to the elderly population, but at the end of the day, we can consider as an elderly patient with multiple myeloma these patients that are really very fit, and at the same time, this patient that is severely frail. And Professor Palumbo in 2005 already defined a model in which the frailty was a prognostic factor in multiple myeloma. And what is most relevant is the power of the frailty impacting in the overall survival is stronger than the presence of high-risk chromosomal abnormalities and, of course, the chronological age. This means that we have to try to evaluate the frailty in our patients with multiple myeloma, especially in the elderly population, because we are going to see how in the future the treatment can be frailty adapted. There are several scores, and you know that the International Myeloma Working Group endorsed this frailty score, evaluating the age, the activity daily living, independent activity daily living, as well as comorbidity. But there are many others. I can say that in Spain, we are utilizing this one, the geriatric assessment in hematology. This score was built by the Spanish group of hematogeriatricians, is applicable to whatever hematological diseases, and definitely it does evaluate the polypharmacy, the gait speed, comorbidities, activity daily living, subjective health status, nutrition, mental status, as well as mood. But definitely the problem of this frailty score is they are time consuming, and in majority of the hospitals, we don't have a geriatricians involved into the evaluation of our patients with multiple myeloma. It is not well established, the identification or how to identify the frail population, but just let me share with you this slide. It is coming from the first clinical trial conducted some years ago, in which, if you remember, lenalidomide and dexamethasone as continuous therapy emerged as the standard of care for the transplant-ineligible population. And in this study, they decided to apply a modified International Myeloma Working Group frailty score. This means that this is more simple, and it evaluates the chronological age, the Charlson comorbidity index, and the performance status. And with these three factors, it is possible to distinguish between frail and non-frail patients. In this first study, in which over 1,500 patients were included, it is important to see how, in spite of the fact that in the clinical trial, patients are usually selected, 790 patients, almost 50%, qualified for frail. And when we look into the baseline characteristics of the patients of this frail population, I would say that they are usually older, as well as poor performance status. And from the baseline characteristics point of view, more patients presented ISS3, LDH elevated, as well as some degree of renal impairment. But also is important, and the outcome definitely for the frail patients included in the first clinical study was inferior in comparison with the non-frail. And this is applicable to the progression-free survival, but also to the overall survival. It's true that maybe this simplified frailty score is not the ideal one, but definitely it has been utilized, as you can see, in many clinical trials in multiple myeloma in order to evaluate the outcome of frail patients utilizing this simplified model. In my mind, I think that how can we overcome the frailty? The frailty as a factor determining high risk in multiple myeloma. And a possibility is the addition of the monoclonal antibodies anti-CD38. Here you can see the Alcyon study, in which you know that daratumumab plus VMP was compared with VMP alone in the transplant-ineligible population. And again, this simplified frailty score was applied, and approximately 40% of the patients qualified for frail. And what we can see here in terms of progression-free survival is how when add the monoclonal antibody, in this case daratumumab, we are able basically to overcome the poor prognosis of the frailty. And indeed, the outcome is not very different for frail, intermediate, or fit. In terms of overall survival, the difference is more evident, and definitely because of the natural chronological age, as well as the possibility of rescue therapies, fit patient resulted in the better outcome. And in the other combination, daratumumab in combination with lenalidomide and dexamethasone, for me it's important to see how when we compare dara-lendex frail population here, and lendex alone in the frail population, there is a big difference. indicating how the addition of the monoclonal antibody daratumumab is going to be able to significantly improve the outcome for frail patients. Anyway, you can see here how fit and intermediate resulted in the better outcome in terms of progression-free survival and also in overall survival. The future, I think that will be frailty-adapted therapy. I don't know how easy it is going to implement this in the clinical practice, but there are already some clinical trials conducted specifically in the fit population. This is the case for these two large phase 3 clinical studies, IMROD and CEPHEUS, in which VRD followed by Lendex in both clinical trials is being compared with VRD followed by Lendex plus monoclonal antibodies anti-CD38, either isatuximab or daratumumab. And these clinical studies had been conducted for newly diagnosed myeloma patients in which the transplant was not planned as part of the first line of therapy. And basically, I can imagine that the patients included in these studies are going to be fit patients between 65 and 70, in which we don't consider the transplant as the first option. The Spanish myeloma group has already recruited these 462 newly diagnosed myeloma patients, elderly but fit, according to the scale I previously showed you in my previous slides. And what we planned in this study is to offer an intensive approach of therapy. The objective is to get outcomes similar to the young population, but in fit, non-eligible for transplant, newly diagnosed myeloma patients. And in this study, we are going to compare VMP followed by Lendex during 18 cycles with carfilzomib, lenalidomide, and dexamethasone, or carfilzomib, lenalidomide, and dexamethasone plus daratumumab. And the primary endpoint is going to be minimal residual disease after 18 cycles. And after this induction, patients who were not receiving daratumumab as part of the induction will receive 4 consolidation cycles with dara-Lendex, and we will evaluate later on the minimal residual disease in order to see if it is better to give the monoclonal antibody since the beginning, or maybe it is possible to consolidate later on. And the maintenance therapy is interesting because it is going to be guided by the minimal residual disease situation. And patients with MRD positive and patients with MRD negative will be randomized 1-to-1 to receive no maintenance versus daratumumab plus lenalidomide. The rationale for the randomization to no maintenance in patients with MRD positive is in order to understand what is the role of a small clone in these patients receiving for the last 2 years proteasome inhibitors, IMiDs, and anti-CD38 monoclonal antibodies. And in the MRD negativity patients, it's also to evaluate what is the role of maintenance if the minimal residual disease is already negative. We will have some preliminary data maybe in 1 year. But also there are some specific clinical trials conducted only in the unfit and in the frail population. And I think this population represents an unmet medical need. This is a clinical trial conducted by the HOBON group evaluating ixazomib, proteasome inhibitor of oral administration with daratumumab and dexamethasone, 8 cycles, for this elderly but frail or unfit population. And the outcome is, I would say, quite good. You can see here how the median progression-free survival for the unfit patient is approximately 2 years, 1 year for the frail population. It is not too bad from my point of view, and especially in terms of overall survival, because I think that one important factor to evaluate in these clinical trials conducted in the frail population is the early mortality rate. And here in this study, I would say that it is acceptable with approximately 7%. And I would say that this is the starting point in order to try to design new clinical trials according to the frailty. This is going to be, from my point of view, the only way in order to offer an optimal therapy for the fit patients and an adapted and soft population. two different populations for which the objectives have to be maybe different. And let me share with you now another disease-specific factors that are going to confer also high risk to patients with multiple myeloma. And one of them is the classical international staging system. You know how when we utilize albumin and beta-2 microglobulin, we are going to be able to distinguish between three different subgroups of patients with different survival, 62, 44, and 30. And 30 months for those patients presenting a beta-2 microglobulin higher than 5.5. This international staging system was built many years ago and published in 2005, but I would say that it does continue being valid in transplant-eligible, transplant-ineligible, patient receiving conventional agents or novel agents. But it's true that the cytogenetic abnormalities as well as the LDH emerged also as important prognostic factor in multiple myeloma. And this was the reason why this international staging system was revised. And you can see here the RISS, in which again, three different subgroups of patients were identified with a different progression-free survival and overall survival. And the main difference with the previous ISS is to incorporate cytogenetic abnormalities, deletion 17p, 414, or 1416, together with LDH. It's true that when we evaluate in detail this revised international staging system, majority of the patients are allocated to the RISS2, and there are right now different approaches in order to dissect this RISS2 group in two different groups, because there are patients that are closer to the RISS1, and there are patients that are closer to the RISS3. Let me focus a bit on the high-risk cytogenetic abnormalities, on the cytogenetic abnormalities conferring a high risk. The International Myeloma Working Group recognized as high-risk cytogenetic abnormalities 414, deletion 17p, and 1416 translocation. However, we know that today we are incorporating also two new cytogenetic abnormalities, the abnormalities of 1q, because we know that plus 1q and especially amplification of 1q, the presence of 4 or more copies of 1q, as well as the deletion of 1p do confer poor prognosis to patients with multiple myeloma. And this is what we are doing right now in our clinical practice. And this would be my recommendation if it is possible to do all these cytogenetic abnormalities. In many centers, well, next generation sequencing is emerging as the gold standard in order to evaluate some mutations, other cytogenetic abnormalities, and if this technique is available, I would recommend to evaluate the mutational status for TP53 because of their prognostic importance. Concerning other mutations, I think that the heterogeneity is huge and we don't have a basically targeted therapy, so I don't recommend to evaluate outside of clinical research, of course, NRAS, KRAS, and so on, because these mutations are not going to be very frequent, and we are not going to utilize this information in order to select the therapeutic options. It's true that the cytogenetic abnormalities may differ in the first and later relapse because of the clonal evolution, and if possible, it would be good to repeat the cytogenetic information across the different lines of therapy, especially if at the moment of newly diagnosed, the patient didn't present any high-risk cytogenetic abnormality. Now that our patients with myeloma are definitely living longer and longer, it is not infrequent to see how in fourth or in fifth line of therapy, we see a small clone presenting, for example, deletion 17p. And in the future or right now, it is possible to utilize clinical classifications combining ISS, serum LDH with some cytogenetic abnormalities. And I would like to share with you this slide. This is a paper published some years ago, but it was done based on the COMPASS study, an approximate 800 newly diagnosed myeloma patients treated with novel agents-based combination in different worldwide clinical studies. And what is important from my point of view is they were able to dissect many different subgroups of patients with a different outcome. And I think that this is important to separate in blue and red patients with an excellent prognosis from those patients in which the prognosis is actually very poor. And today we are discussing about high risk, and this model was able to detect a double hit subgroup of patients with multiple myeloma. This is the node 7, and you can see how this subgroup of patients is identified by the presence of either biallelic TP53 inactivation or amplification 4 or more copies of 1q on the background of ISS3. And when this occurs, we know how the progression-free survival for these patients is going to be only 15 months and the overall survival 20 months. This is a truly high-risk group of patients with multiple myeloma, and also it is good to see how this is applicable to only 6% of the population. And now, how are we going to treat these patients with high-risk features? I previously alluded, according to the frailty, how from my point of view, the incorporation of the anti-CD38 monoclonal antibodies is able to significantly improve the outcome. But if we focus on the population with high-risk cytogenetic abnormalities, it is quite difficult because you know that there is not any combination in principle able to overcome the poor prognosis of the presence of high-risk cytogenetic abnormalities. And this is the reason why you have to keep in mind these two important concepts. The first one is to use the most effective novel agents-based combinations and as continuous therapy if possible for patients with high-risk cytogenetic abnormalities. And the second important concept, to try these patients to achieve minimal residual disease negative and maintain it over time. And I am saying this because here in this meta-analysis published by your colleague and friend Nikhil Munshi some years ago, the undetectable measurable residual disease achievement was independent of, as prognostic factor, was independent of the cytogenetic risk. And when a patient with high risk reach minimal residual disease negative, the prognostic value, the hazard ratio for progression-free survival, was similar to the hazard ratio observed in patients with standard risk. And this has been observed in some of our studies conducted by the Spanish myeloma group. This study included 450 newly diagnosed myeloma patients transplant eligible. They receive RVD, transplant RVD, and maintenance with lenalidomide. And what we can see here, how in the right-hand side of the slide, patients achieving minimal residual disease negative reported a similar outcome regardless of the RISS 1, 2, or 3, indicating that the achievement of minimal residual disease negative overcomes the poor prognosis. By contrast, when we evaluate in the left-hand side of the slide the outcome for patients do not achieving minimal residual disease negative, the outcome is different, and especially patients with RISS3, the median progression-free survival was only 14 months. I am applying here to revised ISS3, but our group dissected also the role of the presence of high-risk cytogenetic abnormalities. And again, you can see how the information is the same. And when we evaluate progression-free survival and overall survival, patients achieving minimal residual disease negative do present the same outcome than standard risk. By contrast, when we evaluated the outcome for patients who didn't achieve MRD negative, patients with high risk in red really presented a poor outcome, not only in terms of progression-free survival, but also in overall survival. How can we apply all this information to the treatment of our patients with multiple myeloma? If we focus first on the newly diagnosed myeloma patients, we can see here the European guidelines, and in principle, there is not any special recommendation for patients with high-risk features. If you read the paper, you can see maybe some recommendations, but there is not any specific combination selected for this type of population. What is the starting point? And I decided to select this paper published some years ago, and it is coming from the observational study conducted by the group of Emory in Atlanta with 1,000 consecutive newly diagnosed myeloma patients treated with RVD, followed by transplant, and continuous therapy with RVD if patients presented high-risk cytogenetic abnormalities. And the median progression-free survival was 40 months, median overall survival 78. And from my point of view, this would be the starting point, and we have to try to improve the outcome of patients with high-risk cytogenetic abnormalities. The first possibility is to add the monoclonal antibody anti-CD38 daratumumab. This has been evaluated in the phase 3 Cassiopeia study, and in principle, we know how the probability of achieving minimal residual disease negative is higher for patients with ISS3 or patients with high-risk cytogenetic abnormalities, indicating, as you can see here in the progression-free survival curve, how the addition of daratumumab is going to significantly improve the outcome of patients with high risk in green in comparison with the VTD alone in high risk in red, but there it is not able to completely overcome the poor prognosis because you can see how the better outcome is observed for DARA VTD standard risk. The Griffin study added daratumumab, I would say, to a more realistic induction regime right now in myeloma, bortezomib, lenalidomide, and dexamethasone, and the same information. The probability of achieving complete response or MRD negativity is higher when we add in patients with high risk, when we added the monoclonal antibody daratumumab. And in terms of progression-free survival, again, the hazard ratio is good, 0.59. In the intent to treat patient population is 0.46, indicating that we are going to improve the outcome of these patients. What about carfilzomib? Because maybe you've heard how, especially in the US, patients with high risk usually receive carfilzomib instead of bortezomib. And definitely, I don't know if this is completely true or not, because the comparison between VRD and KRD conducted by your colleague Saji Kumar applied only to a standard risk patient. So we can't get any conclusion from this study. But here you can see the Forte study, in which KRD was KRD followed by transplant and KRD consolidation was compared with KRD 12 cycles without autologous stem cell transplantation or KCD transplant and KCD. And for me, when the evaluation was done in patients with high-risk cytogenetic abnormalities or patients with a double hit, we can see how the better outcome is observed for those patients receiving KRD followed by autologous stem cell transplantation. And this is better than KRD 12 cycles or KCD followed by autologous stem cell transplantation. So this is important, but for me, it's important to see that when we evaluate the role of carfilzomib as induction regime in patients with high risk, without autologous stem cell transplantation, KRD 12 cycles, or KCD followed by autologous stem cell transplantation, the median progression-free survival in the high-risk population is 37 months or 40 months. And if you remember, this is not different to the median PFS reported by the Emory group in Atlanta with VRD in patients with high risk. It was 40 months. Well, this means that honestly, I don't know if carfilzomib is actually more effective in patients with high-risk cytogenetic abnormalities, or maybe in the Forte study, the real benefit for the population with a high risk and double hit is derived not from KRD alone, but from KRD followed by autologous stem cell transplantation. And this is going to be confirmed, or this has been recently confirmed in this phase 3 determination study published in New England Journal of Medicine, in which transplant was compared with no transplant in all comers newly diagnosed myeloma patients, RVD, 3 cycles, followed or not by autologous stem cell transplantation, RVD consolidation, and lenalidomide maintenance. Transplant was better in progression-free survival in all patients. But when we evaluate, or when Paul Richardson evaluated the outcome in patients with high-risk cytogenetic abnormalities, you can see how there is a clear difference. And those patients who received autologous stem cell transplantation, the median PFS was 55 months. But those patients who didn't receive transplant and presented high-risk cytogenetic abnormalities, the median PFS is only 17 months. Putting in context once more again the great benefit of autologous stem cell transplantation in patients with high-risk cytogenetic abnormalities. Another combination evaluated in the master study was daratumumab in combination with KRD followed by transplant, but the consolidation was adapted to the minimal residual disease. From my point of view, this study can give us 2 important messages according to my 2 principles when you have in front of you high-risk newly diagnosed myeloma patients. You have to try to utilize the best combination, and you have to try your patients to reach MRD negative. And with this approach, and in this study, 57% of the patients were with high-risk cytogenetic abnormalities, 80% of the patients achieved minimal residual disease negative, and this is a good number. However, I previously told you that if possible, patients with high risk had to receive continuous therapy. And in this study, after transplant, when the minimal residual disease was negative and confirmed in a second determination, they stopped therapy. If the MRD was positive, data KRD as consolidation was given for cycles, and if MRD negative, treatment was stopped. And this is maybe a valid approach for patients with no high-risk cytogenetic abnormalities. The follow-up is quite short, but here you can see how this approach for patients with ultra high risk to high-risk cytogenetic abnormalities is maybe not valid, because as soon as patients stopped treatment because they achieved MRD negative, they started to relapse. This is the meaning. It's true, and it's important to utilize the best combination to reach MRD negative, but the treatment has to be continuous in order to try to maintain the minimal residual disease as negative in high-risk patients. Otherwise, the patient will relapse very soon. Tandem autologous stem cell transplantation. Maybe there is a role also for patients with high-risk cytogenetic abnormalities. This was evaluated in this European Myeloma Network clinical trial, but this is an old study because you can see how the combinations are CyBorD followed by VMP, RVD consolidation, len maintenance. But it's important to see how when we focus on patients with high-risk cytogenetic abnormalities, the tandem transplant was able to completely overcome the poor prognosis, and it is the outcome completely comparable to those patients without high-risk cytogenetic abnormalities. This was also confirmed in the STAMINA trial, another clinical study conducted in the US, and in the last update, they showed how, in terms of progression-free survival, patients with high-risk cytogenetic abnormalities do benefit from tandem autologous stem cell transplantation. In this study, again, the induction therapy was free, and the consolidation was RVD, and the maintenance was lenalidomide. And honestly, we don't know if this concept of tandem transplant is applicable to the modern combinations we are utilizing right now, incorporating the monoclonal antibodies anti-CD38. And maybe if we move towards the use of quadruplet combinations, we don't need tandem autologous stem cell transplantation. We don't know, and this is a question mark. Maintenance therapy. You know, lenalidomide is the standard of care, and it is optimal for all comers. In patients with high-risk cytogenetic abnormalities, the efficacy is less evident. Definitely, it does work, but it would be possible to add something else in order to try to improve the outcome of patients with high risk. A possibility is to add the proteasome inhibitor. We utilize in the clinical practice bortezomib because it is generic, but in the fourth study, carfilzomib was added, and you can see here how in the high risk and even in the double hit population, the outcome was better. And daratumumab has been also added to lenalidomide in the phase 2 Griffin study, and again, it can add a potential benefit in patients with high risk, basically derived from the fact that more patients are able to achieve a complete response or minimal residual disease negative. But this is pending of confirmation. As I previously told you, in my practice, I add bortezomib, one dose every 15 days for 2 years to the lenalidomide maintained as continuous therapy. So this is basically the summary for the management of newly diagnosed myeloma patients with high-risk cytogenetic abnormalities if they are transplant eligible. If the patient is non-eligible for autologous stem cell transplantation, again, we don't have any special recommendation. And the starting point in order to see what would be the outcome for patients with high risk is observed in this phase 2 randomized study conducted by Saad Usmani, in which RVD was compared with RVD plus ilotuzumab in newly diagnosed myeloma patients not doing autologous stem cell transplantation with high-risk cytogenetic abnormalities. The addition of ilotuzumab didn't add any significant benefit. This is the reason why we can consider that the median progression-free survival for this population will be of approximately 30-34 months. You can see here how a bit inferior in comparison with the Emory observational study in which patients did receive autologous stem cell transplantation. Daratumumab is not a good partner for VMP in patients with high-risk cytogenetic abnormalities. You can see here how Dara VMP in high risk is better than VMP alone, but there is not a great benefit, and indeed there is a great differences in outcomes for Dara VMP standard risk and Dara VMP high risk. I consider that this is also an important message because you should not choose this combination for patients with high risk, and the ideal combination will be daratumumab in combination with lenalidomide and dexamethasone. In the Maya study, 15% of the patients presented high-risk cytogenetic abnormalities, and you can see here how overall the median progression-free survival was 62.5 months, and in the patients with a high risk, 45.3 months. And from my point of view, I think that this is the longest median PFS we've seen in newly diagnosed myeloma patients non-eligible for transplant with high-risk cytogenetic abnormalities. And this would be, in principle, if this combination is available, the first choice for the patients with high-risk cytogenetic abnormalities. What about the relapse? Well, let me share with you how in the future, as I previously told you, for the fit and frail population, different cooperative groups are conducting different clinical trials focused on patients with high-risk cytogenetic abnormalities. And maybe this is going to be the future in order to individualize and to optimize the treatment. And this is the Optimum trial conducted by the Myeloma UK group in patients with a high risk. And they decided to plan a total therapy approach, but a modern total therapy approach, including daratumumab VRD plus cyclophosphamide transplant, but two consolidation. The first one 6 cycles, the second one 12 cycles. So 1.5 years of treatment after transplant with the Dara VRD or Dara VR alone before moving to maintenance with the Dara and lenalidomide. And this is the preliminary outcome. But what is relevant is they decided to compare with a similar subgroup of patients included in a conventional clinical trial conducted by the Myeloma UK including induction, transplant, and maintenance. And you can see how at 18 months, there is a great difference in terms of outcome, indicating that maybe the optimal way is to treat the population with high-risk cytogenetic abnormalities in a different way. Katja Weissel from Germany is also conducting this clinical study only in high risk, incorporating the monoclonal antibody anti-CD38 isatuximab to KRD, followed or not by autologous stem cell transplantation, depending on the transplant eligibility. The outcome is in principle good, but look how during the first year, there is some patients who indeed relapsed and or died. So maybe it would be good to try to investigate how these patients presenting high-risk features and receiving this optimal combination did progress or did relapse earlier on, because maybe these patients would have specific high-risk features. And what about the relapse and refractory myeloma patients when they present high-risk features? When we go to the different guidelines, and this is applicable to the guidelines endorsed by the International Myeloma Working Group, again, no special recommendation for patients with a high risk. If we evaluate the first relapse with a Lendex-based combination, these excellent combinations that were evaluated in phase 3 clinical study, when we evaluated the outcome in patients with a high risk, it is better than lenalidomide and dexamethasone alone, but definitely, again, these combinations are not able to overcome the poor prognosis. And the same is applicable to all novel combinations. You can see here in the slide, and I am not going to go one by one, DARA-KD, PVD, ISA-PD, or even selinexor, bortezomib, and dexamethasone. When we move from double to triple combination, we are going to improve, but we are not going to overcome. And concerning the novel immunotherapy, or I would say the BCMA targeted therapy, we don't have basically information about the role of belantamab mafodotin, the BCMA antibody drug conjugated, effective in triple class refractory myeloma patients. When we evaluated the efficacy of ide-cel, the BCMA CAR-T, it's important to see how when we focus on high-risk cytogenetic abnormalities, the outcome is quite good for patients with a high risk, with a similar outcome to that reported in the intent to treat patient population. This is not the case when we evaluate the patients with ISS3, and this means that the presence of a beta-2 microglobulin higher than 5.5 resulted in a poor outcome for relapsed and refractory myeloma patients receiving ide-cel. And this is also observed with cilta-cel in the CARTITUDE-1 study. However, overall, I would say that BCMA CAR-Ts are effective in patients with high-risk cytogenetic abnormalities, but again, the outcome is a bit poor in comparison with the standard risk, but we have to put in context that these patients had to receive a median of 7 prior lines of therapy, so maybe these patients would have died in majority of the countries. According to the outcome for patients with high risk, they had the chance for receiving BCMA CAR-Ts, either ide-cel or cilta-cel, and I think overall the outcome is encouraging. With bispecific monoclonal antibodies, honestly, we don't have yet any information because the clinical studies are ongoing at the present time, and I can imagine that maybe the outcome is going to be good, but we don't have any specific subanalysis conducted in patients with high-risk cytogenetic abnormalities. Another important subgroup of patients with high-risk features, functional high risk. And in your activity, for sure, you will see or you've seen patients early relapsing after autologous stem cell transplantation, patients early relapsing after the first line of therapy, maybe within the first 18 months or within the first 2 years. These patients, regardless of the presence of high-risk cytogenetic abnormalities or elevated beta-2 microglobulin, are functional high risk because the outcome is actually very poor. How can we improve the outcome for this functional high risk? From the conventional point of view, the allogenic stem cell transplantation. And this is what we did in the past in our institution. And this was one of the first indications for the allogenic stem cell transplantation in myeloma. And indeed, we did this retrospective evaluation in almost 50 patients. And it's true that allotransplant is not a curative option in myeloma, but the graft versus myeloma does work, especially when we try to enhance the graft versus tumor throughout the management of the immunosuppression if graft versus host disease is not present. And in our experience, at 5 years, 40% of these patients with functional high risk were alive. And according to the outcome I previously showed you, with conventional therapies, these patients would have died, the majority of them. Today, maybe the allogenic stem cell transplantation is not the standard of care, but because we have replaced this old immunotherapy approach by the modern immunotherapy approach based on BCMA CAR-Ts. And it's true that both ide-cel and cilta-cel are being evaluated in this functional high-risk population. And in the KarMMa-2 study and in the CAR-T2 clinical study, there are some cohorts of patients meeting these criteria, functional high risk. And we have today some preliminary information from cilta-cel in 20 patients with functional high risk. After the first line of therapy, they progressed within the first year or within the first 2 years after autologous stem cell transplantation. And here you can see the outcome. Majority of the patients responded. The complete response rate was 80 months. Many patients in minimal residual disease negative, and we needed to wait longer follow-up in order to see if these optimal responses are durable over time, because it's true that these patients are not receiving any maintenance approach, just cilta-cel, but this is important because this is actually a high-risk population. Before finishing the presentation, let me share with you some another type of high-risk features in myeloma. One of them is the extramedullary disease. And in principle, the extramedullary disease, you know that means soft tissue plasmacytoma, plasma cell infiltration of whatever site distant from the bone marrow. And it's true that these plasmacytomas or this extramedullary disease can be paraskeletal when they are adjacent to lytic lesions, or they can be pure extramedullary disease, affecting the liver, skin, CNS, and so on. This is the pure extramedullary disease. This is the extramedullary disease clearly impacting in the prognosis of patients with multiple myeloma. And also, it's important to see how the incidence is very low at the diagnosis, and no more than 4% of the patients, but at relapse, this can increase up to 10%. You know that at the diagnosis as well as at relapse, the liver is the most frequent organ involved by extramedullary disease, followed by chest wall, lymph nodes, skin, paraspinal area, but in principle, whatever organ can be involved by plasma cells evading the bone marrow microenvironment, escaping and inducing extramedullary disease. Important to evaluate the extramedullary disease. In the past, it was difficult because we did only X-ray and physical examination. So in many patients, the extramedullary disease was not detected. But now we have a more sensitive imaging assessment, MRI, as well as PET-CT. And when we evaluate extramedullary disease, it's important to follow them throughout the use of the same imaging technique in order to evaluate the potential complete metabolic response. And this is what the International Myeloma Working Group recommends in order to assess the response in case of extramedullary disease. And I would like to remark again the important concept to utilizing the same imaging technique. Extramedullary disease was also present in some patients treated with ide-cel, and in principle, the outcome was quite comparable to all intent to treat patient population. And we've seen in the clinical practice patients with extramedullary disease and how after CAR-T, the extramedullary disease rapidly disappeared. And the same is applicable to cilta-cel with the CAR-T2D1, although again, this population, we know that is a challenging population and the outcome is a bit poor in comparison with the standard risk population. What about plasma cell leukemia? Again, this is not a very frequent entity, but the prognosis, you know that it is very poor. From the classical point of view, it was defined by the presence of at least 20% of plasma cells in the peripheral blood or more than 2,000 plasma cells in the absolute count in the peripheral blood. Primary plasma cell leukemia is occurring when there is not any previous history of multiple myeloma, but sometimes we see secondary plasma cell leukemia in heavily pretreated myeloma patients. You know that this was the classical definition, but some observations coming from Spain in Barcelona, as well as the Mayo Clinic, put in context how when patients with myeloma presented more than 5% of circulating plasma cells evaluated by morphology in the peripheral blood, the outcome was comparable to that of primary plasma cell leukemia according to the conventional definition. 5% of plasma cells by morphology in the peripheral smears qualified for the definition of plasma cell leukemia. How to treat plasma cell leukemia? This is also a difficult population. Transplant is crucial if eligible. Induction with maybe conventional chemotherapy VDT-based or CyBorD-VTD-RVD, or if possible, daratumumab in combination with VRD. Maintenance with PI and IMiD if possible, as well as a good option to add the anti-CD38 if available, but pay attention to the supportive care because the infections as well as the tumor lysis syndrome are quite frequent and the early mortality rate is important, and we have to try to maintain our patients with all supportive care. Finally, I think that we have to investigate in all clinical trials in order to try to dissect much more the biology of the high-risk myeloma patients. And we have to focus not only on the bone marrow and on the plasma cells, but also on the bone marrow microenvironment, as well as even in the peripheral blood, in the circulating tumor cells that can be maybe responsible from the dissemination, as well as the extramedullary disease. This is my last slide, and I would like to conclude saying that the work is in progress, and definitely we needed to continue improving because, as I previously told you, well, today it is quite difficult to completely overcome the poor prognosis of the high-risk features in general in myeloma. This is the reason why we have to recognize the areas for improvement in order to plan research in these topics, better identification, new approaches such as cell therapy, trials focus on high-risk myeloma patients, and don't forget the strong correlation between minimal residual disease negativity achievement and high-risk features, because when these occur, you are going to be able at least to overcome the poor prognosis of the presence of high-risk features. And I stop here. Thank you very much for your attention.
Thank you, Dr. Maria. Very, very comprehensive talk. You covered almost everything, all the advances right up to CAR-T, bispecific, etc. Thank you so much. So we have some of our colleagues here and they may be interested in asking some of their questions.
I would like to, have some my share of ideas. Ma'am, thank you so much. You have a very nice presentation. I was also always wondering about, some of the patients that we encounter. We are in a tertiary care center, and we always get patients from the centers who have already transplanted and then relapsed. Very difficult to manage those kinds of patients. In these sittings, ma'am, we would like to go for allogenic transplant if matched siblings is available. But my main concern is where, ma'am, if those patients where matched sibling is not available, how much is the allo reactivity provides anti-myeloma effect in this kind of high-risk relapsed myeloma patients? Number one, what is your preferred conditioning regimens in this kind of patients? Because these are always elderly patients, and they have many comorbidities associated with them. And my third question is regarding plasma cell leukemia. We have many plasma cell leukemia patients in the last 2 years, and every one of them have died. So we all use VD-PACE as the induction chemotherapy. And I really like to know what strategies do you use, because we have not been able to get past the first month of therapy.
Well, thank you very much for your questions. And I think that you alluded to this difficult population. First, the functional high-risk myeloma, those relapsing earlier on after autologous stem cell transplantation. As I previously told you, from the classical point of view, our option was allogeneic stem cell transplantation. The crucial aspect for us sometimes is to put in remission to these patients before going to allogeneic stem cell transplantation, because at the beginning we did allo transplant in patients with high tumor burden, and none of these patients was able to survive because we didn't observe the graft versus myeloma. In order to exploit the graft versus myeloma, point number one, patients have to go to allo at least in partial response. As a majority of these patients had been previously treated with high-dose melphalan, we usually utilize reduced intensity conditioning regime, and we try to avoid again melphalan. This is the reason why in many patients we utilize busulfan plus cyclophosphamide or busulfan plus fludarabine, trying to avoid again the melphalan. But honestly, I have to say that right now there are many years, at least 3-4 years, in which we don't do any more allogeneic stem cell transplantation. But this is basically because we have the modern immunotherapy approaches, is basically either clinical trials with bispecific monoclonal antibodies or CAR-Ts. And concerning plasma cell leukemia, well, it's true that we don't see many patients with plasma cell leukemia. The latest patients we've seen with plasma cell leukemia, if they are young, we do induction usually with VD-TPase or VD-TPase replacing thalidomide by lenalidomide. And if we see response and the patient is young, this is the only population in which we plan auto followed by allogeneic stem cell transplantation with reduced intensity conditioning regime. But I repeat, I think that we did this last time, maybe 1.5 or 2 years ago. If the patient is not eligible for transplant, we try to utilize the best combination of possible. If it is eligible for DARA VRD or DARA index, or if it is possible to utilize some chemotherapy, but maybe the elderly population are not eligible, and we plan to continue with this therapy, but we know that the outcome is going to be very poor. And the problem is that we don't have specific clinical trials conducted in plasma cell leukemia, and a majority of the clinical trials do consider the plasma cell leukemia as exclusion criteria. This is the reason why we don't have evidence enough in order to know how to proceed with this difficult population. I don't know even now with this modern definition, more than 5% of plasma cell, it is possible to include, I would say, more patients with plasma cell leukemia, and the clinical trials can potentially allow us to include these patients, and this is the only way in which we will have information. You have to know that from the International Myeloma Society point of view, we are going to have a meeting, 2 days meeting with FDA in November, and the idea is to plan them all these type of questions that they are not addressed in the clinical trials, and we are going to ask them, for example, why not to include plasma cell leukemia in these clinical trials, and maybe analyze it in a separate way, because they can potentially impact in the overall outcome of all comers. But I think that we need to evaluate novel approaches in these patients.
Thank you.
Thank you, ma'am.
Thank you, Asif. Meher, your question. Okay, till that time, Dr. Eni, your question.
Thank you, sir. Thank you for the opportunity. Thank you, Dr. Maria, for such a brilliant talk. Yes, I just wanted to know your opinion on functional high-risk myeloma. You said, yes, that's a very difficult cohort to treat. So what do you think are the factors, the features that we should look for at the time of diagnosis that will help us to identify, though we do not have set criteria, but what probably in your opinion we should look for and watch out? Yes, these may turn out to be functional high risk, because at presentation they never have any such risk factor.
Yeah, so this is an important question. I put a slide representing the outcome of functional high-risk patients, and this is coming from a publication in British Journal Hematology 2021, and the authors are the Myeloma UK group. If you go to this paper, you can see how they identify, well, they evaluate the baseline characteristics of these functional high-risk patients. And in principle, these early relapsers presented at the baseline situation with lower levels of hemoglobin, lower levels of platelets, higher plasma cell bone marrow infiltration, higher beta-2 microglobulin, ISS3, and it's true that some patients with high risk or ultra high risk cytogenetic abnormalities. But in our clinic, and for us, this is the main group of patients, are those with no high risk cytogenetic abnormalities at the baseline situation that they do early relapse. We have in Spain a project called Amadeus study, in which we are doing next generation sequencing in these patients. And we don't have yet the results, but for me, this is the critical question. If a patient do not present any high risk cytogenetic abnormality and they early relapse after transplant, what happens? And this is what we are investigating throughout mutational panels, because definitely something has to occur in order to predict this poor outcome. But I don't have the results yet.
Thank you, ma'am.
Thank you. Dr. Meher.
Madam, I have a few questions. Do you ever prefer KRD over VRD as induction therapy? And in which particular subset you prefer tandem transplant? Is there any particular group where you identify and you want to do tandem transplant? And a third question is in maintenance. The patient has toxicity to doublet. We are seeing peripheral neuropathy with bortism in a few and which is troublesome in a few patients. In such patients, what maintenance? It is len alone, or what else you prefer as maintenance therapy?
Okay, so the first question, RVD or KRD for patients with high risk, we utilize VRD because KRD is not approved. And as I previously told you, well, I don't have a very clear scenario in order to confirm that carfilzomib is better than bortezomib in patients with high risk, because I personally consider that the efficacy of carfilzomib is dose dependent. And if you combine with lenalidomide, you have to reduce the dose to 36 milligrams per square meter. And the endurance study didn't show any benefit for carfilzomib over bortezomib, and this is the reason why we utilize bortezomib. It's true that there are some trials ongoing evaluating the role of carfilzomib, specifically in patients with high risk. We will see the outcome, but I have to say that these trials are not randomized. And the ideal way would be to randomize high-risk patients to bortezomib versus carfilzomib, but we utilize bortezomib. Concerning the second question, was based on the tandem autologous stem cell transplantation, and I think that there is a clear benefit for patients with high-risk cytogenetic abnormalities if they receive conventional induction regimes. This means VTD, Cyborg-D, or even bortezomib, lenalidomide, and dexamethasone. And this is what we do. But a special recommendation, tandem transplant, assuming that the first transplant has been effective. This means that if I have a patient with high-risk cytogenetic abnormality and the patient was in complete response with minimal residual disease positive before the first transplant, and after the first transplant and before the second one, the situation is the same, I have to assume that the first transplant has not been effective and I don't go to the second one. But if I evaluate the response to the first one and I consider the patient is sensitive, I proceeded to the second autologous stem cell transplantation. What I don't know, and honestly, we have to put a question mark, is to the novel induction regimes. If you utilize in a high-risk, newly diagnosed myeloma patient, dara-VRD or even dara-KRD as induction, followed by transplant, do we need the second autologous stem cell transplantation? Honestly, I don't know. But in the clinical practice, I will apply the same concept. If I consider that the patient can get a significant benefit because the response improved after the first transplant and the patient does accept to go to the second one, I will go to the second one. I think that the transplant is very effective for patients with high-risk cytogenetic abnormalities. And the last question was based on maintenance. And well, lenalidomide is effective, but it's not enough because the outcome is well, better for standard risk patients. As I previously told you, this is the reason why we add bortezomib. Bortezomib every 15 days for 2 years, based on the finding observed in a Spanish myeloma group clinical trial, in which we utilize bortezomib in combination with thalidomide as maintenance, and we've seen some effectivity or some superiority in patients with high-risk cytogenetic abnormalities, as well as the HOBON group that they conducted another clinical study with bortezomib, 1 dose every 15 days for 2 years, and they found a benefit in patients with high risk, if I remember well, especially in patients with deletion 17p. This is the reason why we do this, but honestly, we don't know if this is the correct approach. But I think that the proteasome inhibitor added to the immunomodulatory drug adds a benefit for patients with high risk, and we will see what happens with the monoclonal antibodies anti-CD38. Thank you, ma'am. Thank you.
Thank you. Vivek?
Good morning, Professor Matthews. Thank you very much for that wonderful talk. I have 3 questions. The first question would be, how would you treat a very young myeloma patient outside the setting of a clinical trial, someone who's presenting in his 30s or early 40s? The second question is, with the variant use of different periods of induction, different trials have used induction consolidations which have extended for a year or more than a year as well. What would be your suggestion for a hematologist sitting in the clinic for a patient who is transplant eligible as well as non-transplant eligible? What is the optimal duration of induction? Is it 6 months? Is it 9 months? Is it a year? What is your suggestion in this setting? Is it going to be response guided? And third question is probably a personal question. What is your definition of an operational cure for myeloma? Thank you very much.
Okay, thank you very much. First question, very young, newly diagnosed myeloma patients in the 30s or in the 40s. Now our standard of care is, our standard of care was bortezomib, lenalidomide, and dexamethasone. And in Spain, recently, approximately 2 months ago, daratumumab in combination with VTD was approved. This means that we can utilize either dara-VTD or bortezomib, lenalidomide, and dexamethasone. And as lenalidomide, its patent expired also this year in Spain, this means that now lenalidomide is a very cheap drug in Spain. And I can say that it's even cheaper than thalidomide. This is the reason why we can utilize daratumumab in combination with bortezomib, lenalidomide, and dexamethasone. And this is becoming our new standard of care. And this is what I would utilize in a young, newly diagnosed myeloma patient. I will proceed with autologous stem cell transplantation, followed by consolidation based on the response achieved after autologous stem cell transplantation. This means that if after transplant the minimal residual disease is negative, we go directly to maintenance therapy. And if the patient is not in MRD negative, we go to consolidation. And in this young patient, well, if the patient was receiving data VRD as induction and the minimal residual disease is positive, I would like to utilize a different consolidation, maybe to go to carfilzomib or something like that in order to put this patient in minimal residual disease negative before starting maintenance. If the patient is a standard risk, lenalidomide single agent is the standard of care. But if the patient is 30 or 40 years old, it is quite difficult for me to plan continuous therapy until progressive disease, because this means that this patient could potentially be on maintenance for 10, 12 years with the risk of second primary malignancies or poor tolerability. And definitely we are planning stopping reuse for maintenance based on the minimal residual disease. And we have some data presented at ASH 2021, in which if at 2 years the minimal residual disease is negative, we can potentially stop lenalidomide, because in principle, the outcome for these patients in our clinical study is quite good, and only few patients relapsed. And this would be maybe what I would offer today to a very young patient with a newly diagnosed myeloma. Your second question is critical, the optimal duration of induction. And I would say that especially for the transplant eligible population. And from my point of view, if you go to the registration clinical studies, especially conducted by the pharmaceutical companies, they try to reduce the number of induction cycles. They try to utilize the poorest as possible control arm in order to win. But in the real life, the situation is different. And in Spain, we decided to move to 6 induction cycles. And we've seen how between the 4th and the 6th, there were approximately 20-25% of the patients who were able to upgrade the quality of the response. In the clinical practice, how do we proceed? We start induction, we monitor the response every cycle. After 3-4 cycles, we collect the peripheral blood stem cells and we evaluate the kinetic of the response. If the patient is already in complete response, we go to transplant. If the patient is not in complete response, but we see that the patient has been very sensitive and the M component is going down cycle by cycle, we go up to the 6th cycle, trying to improve the quality of the response. By contrast, if when we evaluated the kinetic, the patient is more or less in a plateau phase since the 3rd cycle, we go to transplant and we don't give the 2 additional cycles. And this is what we basically do as part of the induction. As part of the consolidation, I would say the same approach. When you go to the clinical trials, 4 induction cycles, 2 consolidation cycles. For me, consolidation means something in order to upgrade the quality of the response, to improve, and if possible, to put patients in MRD negative before going to maintenance. Well, why do I have to do just 2 consolidation cycles? If I see that if I give 3, maybe I can get MRD negative. This is what we usually do in our clinic, and we try to adapt the durability of the consolidation based on the response. It's true that you know that in Spain, the health system is public for majority of the patients, and once RVD is approved, we can utilize without any restriction according to the number of cycles. So if there is any restriction by insurance policies and so on, maybe we should restrict to the number of approved cycles. But in the clinical practice, this is what we do. In the transplant ineligible population, the situation is a bit different. Our standard of care now is DARA in combination with Lendex, and we plan continuous therapy, although it's true that our plan maybe is once the patient achieves an optimal response, maybe complete response. My idea is to stop maybe the dexamethasone and even to reduce the dose of lenalidomide based on tolerability. We don't have this experience yet because it has been recently approved, but maybe it does not make sense to maintain it to a 76-year-old patient with a DARA, Len 25 and Dex 40 weekly forever. So I think that we can potentially plan some discontinuations for dexamethasone and dose reduction for lenalidomide in order to make the combination more convenient and more friendly for the patient. And the last question, operational cure. So for me, cure means basically disease-free, treatment-free. And this means that, well, the survival of a cured myeloma patient will be comparable to the survival of another subject with no myeloma with the same sex and age. And this is the cure. And I think that in order to try to achieve the operational cure, definitely we have to work on risk and response adaptive therapy. We have to plan the cure for fit and standard risk newly diagnosed myeloma patients, ideally to try to utilize the best combinations and based on minimal residual disease, negative and sustained over time, maybe at 1 year or 2 years, stop therapy, and to see if this is able to cure some patients with myeloma. But we don't know yet, because definitely we need a longer follow-up in order to see if this is true. But this is my idea in principle.
Thank you, Professor Matthews. One closing question. Do you see in the near time that treatments like CAR T cell therapies would be coming upfront in the treatments?
Yes, sure. Yeah, there are at least right now 2 clinical trials ongoing. One of them evaluating cilta-cel instead of autologous stem cell transplantation. This is the CARTITUDE-6 clinical study. And there is another one that it is also ongoing, the CARTITUDE-5, evaluating cilta-cel after induction with VRD in patients non-eligible for autologous stem cell transplantation. When you see the design of these 2 phase 3 clinical trials, the main conclusion is if cilta-cel is better than the control arm in both clinical trials, well, the distinction between transplant eligible and transplant ineligible would disappear, and we would plan CAR-T for whatever fit newly diagnosed myeloma patients. But there is another planned clinical trial with ide-cel evaluated as consolidation after autologous stem cell transplantation. So I think that many clinical trials, at least 3 randomized, trying to put or to evaluate the role of CAR-Ts in the upfront setting. The challenging question for me is the maintenance, yes or not, because we have some patients included in clinical trials with CAR-Ts receiving maintenance therapy. And I think that the role of immunomodulation after CAR-T is going to be maybe more important in order to maintain the durability of the response. But we will see.
Thanks much, Professor. Thank you very much. Thank you, Professor Agarwal, for the opportunity.
Thank you. Dr. Aishwarya?
Thank you, sir. Actually, the raise hand sign is not, I'm not able to see that. Thank you, ma'am, for extensively covering like almost all our queries. Just to a few short queries. Role of venetoclax, ma'am, in myeloma?
Yeah, sure. This is an important question. And venetoclax was evaluated first in all comers in relapsed and refractory situation in the Bellini study. And venetoclax added a benefit to bortezomib and dexamethasone in PFS, but the problem was the overall survival. For me, it's important to see how at the last ASH meeting, the Bellini study was updated. And with a median follow-up right now of approximately 4 years, the superiority in PFS was maintained and the deleterious effect in overall survival turned to disappear, maybe because the deaths were related with the toxicity and infections at the beginning. But the most important information is the benefit is observed in patients with 11-14 translocation. This is the reason why the new clinical trials conducted with venetoclax focused on 11-14 translocation patients, and we are awaiting for the results of the phase 3 CANOVA study, in which venetoclax and dexamethasone has been compared in relapsed and refractory myeloma patients 11-14 translocation with pomalidomide and dexamethasone. If this study is positive, that we hope it will be, we will have the first targeted therapy in patients with multiple myeloma. And I think that we will utilize venetoclax and dexamethasone. We know that venetoclax combines quite well, especially with the proteasome inhibitors, carfilzomib, but also with the monoclonal antibody anti-CD38. And there are exciting information in combination with the daratumumab. So I think that now many patients worldwide are receiving venetoclax if they present 11-14 translocation because of its approval in other hematological diseases. But my recommendation is to wait until the results of the phase 3 randomized study are ready. That I think that this is going to occur at the end of this year or at the beginning of the next one.
And thank you, ma'am. As you mentioned, ma'am, that extramedullary myeloma can be noted at baseline also at the time of presentation. So MRI and PET-CT routinely, it's not possible. So which subsets of patient should we like insist or like advise them to go for the procedure so that we don't miss these?
Well, this is a difficult question because it's true that the extramedullary disease has been underestimated over the years because only the physical exploration was the technique available. Well, if you have to select the patients eligible for an additional imaging technique to evaluate the potential presence of extramedullary disease, maybe patients with high tumor burden, patients with low levels of platelets, hemoglobin, elevated LDH is critical, patients with high-risk cytogenetic abnormalities, maybe these patients, young patients in which you plan, well, a more intensive option of therapy or novel combinations. Imagine you can utilize DARA VRD in a patient. I think that it is important to evaluate very well the disease in this type of patients.
Yeah. Another case scenario, just one of my colleagues wanted to discuss myeloma with gain 1q, deletion 13q, and translocation 11-14 post 2 cycle DARA VTD. So even after 2 cycles or 2 months, the FLC ratio is still greater than 100. So should we continue or like should we consider modifying our therapy?
And what was the level at the baseline situation?
It was positive, ma'am, greater than 100. I don't have the exact values, but
well, I think that after just 2 cycles, maybe you can evaluate what I previously said to your colleague, the kinetic of the response. If you don't see any response, definitely it's important because after DARA VTD, but maybe you can replace thalidomide by lenalidomide in order to see if the response is more evident or not. But if you see some types of response, you can continue. Definitely, if you don't see any response, you have to change. And in this case, again, don't forget the chemotherapy because this patient will be, I would say, resistant to anti-CD38 proteasome inhibitor IMiD. You can replace thalidomide by lenalidomide, bortezomib by carfilzomib, but maybe if you prescribe a conventional chemotherapy, just 1 cycle or a couple of cycles, you are going to see a response. And this is extremely important because if I remember well, this patient presented 11-14 translocation, correct? Yes. Yeah. These patients are very sensitive to the chemotherapy. You can go to different publications and you can see how transplant and conventional chemotherapy is very effective in this population.
One last doubt, ma'am. It's not pertaining to high risk. I have a standard risk patient post auto myeloma, post auto SCT. So some 7-8 months started on lenalidomide maintenance. So some 7-8 months through maintenance, he started developing thrombocytopenia. Like it came down to some 20,000-30,000. So len was initially tapered and then stopped. Then we ruled out all other causes for thrombocytopenia, and recently it's almost 1 year, and still the platelets are at around 20,000. So we did a marrow. It's like less than 5% plasma cells. So it's not that, and the biochemical parameters are also not suggesting disease progression. So he's off any sort of maintenance right now. So what option do we have for him right now, ma'am? And for the platelet part and for the maintenance part?
Well, maybe you have to try to evaluate the reason for this thrombocytopenia, because it's true that lenalidomide can induce thrombocytopenia, but it's not the most frequent hematological adverse event. You have to ask to the morphologist or to the pathologist by the megakaryocytes in the bone marrow, because maybe you can have in front of you like ATP or something like that, and maybe with some courses of corticosteroids, the platelet levels can go up. You can also evaluate the potential presence of antibody antiplatelets. If you discard everything and you see just thrombocytopenia, that maybe it can be even related with the chemotherapy before autologous stem cell transplantation, the high dose melphalan. In this case, if the patient has a poor bone marrow reserve with 20 or 30,000 platelets, it is possible to prescribe bortezomib sub-Q every 15 days in order to try to maintain the response.
Any TPO and receptor agonists, do they have a role?
Well, this is another possibility, but honestly, I don't have any experience. If you would see something related with ITP, with well, autoimmune thrombocytopenia, I will start maybe with corticosteroids, and if the response is not optimal, to go to a thrombopag or Nplate. But honestly, I don't have any experience in this type of situations.
Thank you so much, ma'am. Thank you, sir.
Thank you, Dr. Aishwarya. Ma'am, can we take some questions from the audience? Dr. Maria, if you have time, can we take some questions from the audience?
Yes, sure.
Okay. There's one question about antimicrobial prophylaxis. PCP prophylaxis, antibiotic prophylaxis. Do you recommend anything during the induction phase?
Well, this is a difficult question, and I would evaluate the risk for infections. And we usually plan levofloxacin as prophylaxis, antibiotic prophylaxis, but only in the elderly population and during the first 3 months, and because the microbiology department allows us to use levofloxacin based on the microbiological environment in our hospital, because I know that sometimes this is not allowed based on the microbiology environment. So you have to ask to your departments. But we usually use levofloxacin in elderly patients during the first 3 months. We don't use conventional anti-PCP prophylaxis, but with the conventional induction regimes, because now we are not using high-dose dexamethasone. We use only 40 milligrams weekly or 20 in the population older than 75. But it's true that this infectious prophylaxis is evolving, especially with the incorporation of the novel BCMA-targeted therapy. And with these novel approaches, the prophylaxis are changing. But today, with the conventional regimes we have, we use prophylaxis in patients with high risk during the first 2-3 months, and later on we stop, and we use, of course, antiviral prophylaxis with acyclovir, basically in all patients receiving either daratumumab or bortezomib.
Thank you. Another question is 45-year-old, newly diagnosed, double-hit myeloma. Role of allotransplant versus tandem auto as after the first treatment. Patient has a matched sibling donor.
Well, this is a difficult question because there are not many randomized study comparing tandem auto with allotransplant. There is a clinical trial conducted by the German group, an update a couple of years ago, showing not a very clear benefit for allotransplant versus tandem, but it's true that not specifically in a patient like you described, 45 years and double hit. So my option would be basically based on the possibilities that you have at the moment of the relapse. For us, allotransplant now is not usually done, basically because we have many clinical trials, and allotransplant is an exclusion criteria for majority of the clinical trials. And this is the reason why I would prefer tandem autologous stem cell transplantation. But if you envision that the patient is not going to be eligible or is not going to be candidate for clinical trials with novel approaches. Maybe if there is a donor available, auto transplant followed by allotransplant with a reduced intensity conditioning regime, or maybe allotransplant with myeloablative conditioning regime since the beginning would be a possibility.
Thank you. There's one question about 1Q amplification. KRD ASCT does not benefit subgroup of 1Q amplification. So what is your strategy in a newly diagnosed such patient? Is there a role of CKS1B?
Well, this is a question, honestly, I don't have the true answer, because I think that there are many debates around the amplification of 1Q. It's true that this was observed in the Forte study, but I think that it is quite difficult to conclude that carfilzomib, lenalidomide, and dexamethasone followed by transplant is not effective in patients with amplification of 1Q, because, well, the ideal answer would be, please add isatuximab, because if you go to the clinical trials conducted with isatuximab, they evaluate the outcome in patients with plus 1Q and they say it does work. So I think that we need much more investigation. I think that amplification of 1Q, the presence of 4 or more copies of 1Q, is a high risk cytogenetic abnormalities, and patients should be treated with the best combination, trying to achieve minimal residual disease negative. But just plus 1Q, so to have more than 2 copies of 1Q, is the most frequent cytogenetic abnormality we see in myeloma, and over 40% of the patients do present this cytogenetic abnormality, and I think that not all patients do present a high risk. Maybe we have to try to evaluate other cytogenetic abnormalities, and the presence of plus 1Q with another one, 414 or deletion 17p, is actually of a poor prognosis. So honestly, I don't have the true answer to this question, because I repeat, many sub-analyses are being done in the clinical trials, but they are not solid enough.
Thank you. One question is about exact placement of DARA in a transplant eligible patient. Will you use it in induction and not use it later on? Or will you not use it in induction and use it later on?
Well, I think that we have to try to utilize always the best combinations as part of the first line of therapy. It's true that the Griffin study is a phase 2 randomized study, and this trial was not designed in order to see benefit in progression-free survival or overall survival. And the Cassiopeia study, the follow-up is approximately 45 months, and we see a significant benefit in PFS with a trend in overall survival. Although it's true that in the transplant-eligible population, we need maybe longer follow-up in order to see the benefit in overall survival. The curves already started to separate. I think that when we use DARA as part of the first line of therapy, we are going to benefit to more patients, because 100% of the transplant-eligible population will benefit. And I think that the benefit is greatest. So this is the reason why I think that it is not a valid concept to reserve the anti-CD38 monoclonal antibody at the moment of the relapse. If you plan your combinations definitely based only on overall survival, Cassiopeia study do not have benefit yet in overall survival. But I think that the benefit in complete response rate, minimal residual disease negativity rate, as well as progression-free survival are solid enough and good surrogate markers for what we can see maybe later in overall survival.
Thank you. We have received some more questions. In present drug trials, what is the endpoint being looked at? Is it now the MRD negativity?
Sorry, can you repeat me the question?
In the present new drug trials, is MRD negativity is the point being looked at?
Yes, sure. The ideal situation is to have a minimal residual disease as the primary endpoint. because, well, the primary endpoint was going to be reached earlier on than to wait until the progression-free survival occurs, because now this means that we have to wait maybe 5, 6, or 7 years in order to have the results of the new clinical trials. But on the other side, well, the International Myeloma Society, as well as the International Myeloma Working Group, are working with the authorities, FDA, European Medicine Agency, and so on, in order to them to accept minimal residual disease as a primary endpoint. This is not a valid approach yet, because authorities were asking by surrogacy and more data. This means that all new clinical trials that are ongoing are collecting information in a centralized way about minimal residual disease, and we will need maybe 2 or 3 additional years in order to get MRD as primary endpoint in clinical trials. And now this is a co-primary endpoint, and for registrational trials, we needed to wait to have a benefit in progression-free survival. But the cooperative groups are planning minimal residual disease in all clinical trials, and we are generating a lot of information about response-adapted therapy, what is important, because many new drugs are coming, and it is impossible to complicate or to add novel drugs to the previous ones, because at the end, we are going to prescribe to the patients an alphabet of drugs if we add and we don't replace anything. And I think that the optimal way in order to see what drug can be eliminated or can early stop it, I think that the minimal residual disease can help us. And I think that this is relevant.
Thank you. And this is MRD by flow?
Well, MRD by flow or MRD by next generation sequencing. Again, FDA recognized next generation sequencing through adaptive as the approved technique for minimal residual disease evaluation in the US. But in Europe, we do usually next generation flow, and there are some publications indicating that when you do next generation flow, analyzing at least 10 million of events, the sensitivity level is comparable to next generation sequencing, and both techniques are comparable. And indeed, we do in routine next generation flow, and in clinical research, we do both techniques. And this is the optimal way in order to compare results and outcomes in patients.
Thank you. The other question is about deletion 1p. How bad is this?
Again, I think that we don't have a solid information or solid evidence about the presence of deletion 1p, but I think that by contrast with amplification of 1u or just a plus 1q, I think that deletion 1p is a high-risk cytogenetic abnormality. Is not so frequent as plus 1q, and we should consider it as a high-risk cytogenetic abnormality. The problem is, from the formal point of view, we have to wait until the International Myeloma Working Group updates the high-risk definition in myeloma, because today we have to continue utilizing the oldest one, and it does include only 414, 1416, and deletion 17p. But there is a new classification in which deletion 1p is going to be added.
Thank you. And the significance of biallelic TP53 mutation is equal to deletion P.
Yeah, this is extremely poor. And this is the only situation in which, if next generation sequencing would be available, it would be of great value to analyze the potential biallelic inactivation of TP53, because to have a monoallelic inactivation of TP53 is bad as well, and this has been reported by the French group in Blood a couple of years ago. But if you have the biallelic inactivation, well, you have to know that the prognosis is going to be very bad.
Thank you. What is the present status of 13 monosomy by conventional karyotyping?
Well, honestly, I don't know. It was included in the conventional classifications. Honestly, I don't know, because we don't do any more conventional karyotyping. So I honestly, I don't know what would be the true answer. So whatever thing I can say, maybe it's not true.
Fine. If you have a standard risk myeloma, by using aggressive protocol, 4-drug induction, tandem transplant, double drug maintenance, do you think you can cure more patients?
High risk or standard risk?
Standard risk.
Standard risk, maybe. Maybe you can cure these patients. If the patient is achieving a minimal residual disease negative, maintained over time, you stop maintenance therapy, this population, this patient could be potentially cured. I think that this is not applicable to the high-risk population. I think that this is a population difficult to be cured because in principle, I think that these patients benefited from continuous therapy. And today, I think that this is not a curable population.
The next question is about this CAR-T between the two, ide-cel and cilta-cel. Is there any benefit of one over the other, superiority?
Well, when we look into the efficacy results from KarMMa-2 and CAR-T2-1, it seems that cilta-cel is better than ide-cel, basically because the populations are, I would say, comparable. Heavily pretreated myeloma patients after a median of 7 prior lines of therapy, more than 80% of the patients triple drug class refractory, and ide-cel was effective, but cilta-cel was very effective because all patients responded. 80% of the patients achieved complete response. And in terms of outcomes, well, with ide-cel, the median progression-free survival was 9 months. And with the cilta-cel, the median PFS has not been reached yet, but it will be around 30 months. So it seems that it's better. But it's true that it is difficult to do cross-trial comparisons because, for example, the KarMMa-2 in the ide-cel, majority of the patients received the lymphodepletion with a high tumor burden because it was not allowed to utilize, I would say, new bridging therapy, and the bridging therapy was based only on maintaining the disease because they wanted to evaluate the role of ide-cel with a lot of disease in order to avoid interferences with the bridging therapy. This didn't happen in the cilta-cel, in which some patients already responded to the bridging therapy. So there are some differences, but in principle, it seems cilta-cel to be better than ide-cel is true.
After CAR-T, if you have severe pancytopenia, hemoglobin, white cell, platelet, all down for prolonged period, is it procedure related and what is the outcome?
Yeah, definitely it is toxicity related, maybe related with the lymphodepletion conditioning regime and also derived from the activity of the CAR-T. And it's true that in majority of the patients, these cytopenias do usually resolve. In sometimes you have to wait until 2 or 3 months, but you see how finally majority of the patients do recover the bone marrow reserve. You need to take care about the platelets with transfusional support and especially neutropenia, because infections can occur. So we have to utilize G-CSF, but also adequate prophylaxis, antibacterial, antiviral, anti-PCP, and sometimes even antifungal if the patients were receiving corticosteroids because of CRS or other toxicity. And this is what we have to take care during these prolonged cytopenias to try to avoid severe infections. But majority of the patients do recover.
Right. Those patients who relapse after CAR-T, can they be subjected to CAR-T again?
Well, we don't have a lot of experience, but in the KarMMa-2 clinical study, it was allowed to do this. And in patients in which CAR-Ts were stored, it was possible to administer them again. And I think that in majority of the patients, no response was observed. But maybe I think that we have to work on this, and maybe if we consider that a mechanism of resistance to CAR-T can be the T-cell exhaustion, why not to wait and to have another line in between with immunomodulatory drugs or checkpoint inhibitors, trying to restore the immune system and to put again a second infusion of CAR-T. This is a possibility. Another possibility is to check if the BCMA is present, because we've seen how some patients lose the BCMA expression, so it does not make any sense to put again a BCMA CAR-T. So I think that all these type of situation, or the generation even of antibodies anti-CAR-T, that it does occur in some patients, well, I think that we have to evaluate the mechanism of resistance in order to see if it is possible to do a second infusion after the first relapse. We are going to do this in a patient maybe in a couple of months, and we will see. The patient has been in response for almost 2 years, and we consider that maybe this has been also relevant, and well, we hope to see any response.
Thank you. One last question put up is there any role of BTK inhibitors in myeloma?
I don't think so. There were some clinical studies trying to evaluate the role of ibrutinib in combination with bortezomib, and I think that the results were not positive, and the trials stopped.
Thank you, Dr. Maria. That's the last question we have. We took you a lot of time. You've been with us for 2 hours. You answered all the questions. We enjoyed it, learned a lot, and I'm sure all these guys who have logged in, and we have huge number of people who have logged in from almost 25 countries. They all must have benefited a lot. And I request you to keep helping us in future as well. Thank you.
No, thank you very much. And well, Dr. Awar, you have my presentation. If someone in the audience would like to have the presentation, you can share it with them, no
Yes.
problem.
Yes, so we have Dr. Maria's presentation. It will be put up at the MSG website. There is no password. You can just go there and download the presentation. Thank you so much for that generosity. Thank you. Thank you.
Thank you. Have a nice day. Bye-bye.
Bye.